warahmatullahi wabarakatuh. I am Dr. Najdi Idris, and I'd like to thank the organizing committee for inviting me to be a part of this scientific meeting. Today, my talk is about CTD associated pulmonary arterial hypertension, about the prevalence, screening, and diagnosis. This is my disclaimer. Now, I want to start by saying pulmonary hypertension is not a disease per se. It is just a hemodynamic state defined during right heart cath by measuring the mean pulmonary artery pressure. Once it's scored more than 25, that will be changed soon to 20 in the newer guidelines, then we have a diagnosis of pulmonary hypertension. Now, as I said, this is just like a hemodynamic state that can be associated with many diseases. But the important problem here, or the point is, whenever you have pulmonary hypertension, then the outcome is much worse. Now, at the moment, we are classifying pulmonary hypertension into 5 groups: Group 1 PH, Group 2 related to heart disease, Group 3 lung disease induced, Group 4 chronic thromboembolic, and Group 5 are the multifactorial. Now, when it comes to the connective tissue diseases, you can see that it can affect all groups. So CTDs can cause pulmonary arterial hypertension, where there is basically vasculopathy. Group 2, it can induce left heart disease related PH. It can cause hypoxia and lung fibrosis, leading to Group 3, and a chronic event leading to Group 4 CTEPH. Now, when it comes to the outcome, it seemed that the rheumatologists have done a great job in reducing mortality when it comes to the renal crisis in a scleroderma patient. As you can see, the mortality is still unacceptably high when it comes to the pulmonary complication. And this is true whether you have basically parenchymal lung disease or more pronounced when you have pulmonary arterial hypertension, when the mortality became very, very high, at least in a scleroderma patient. As you can see that the median survival is less than 2 years in those patients if they are not really treated well. So this is why all guidelines recommend to have a structural screening program in patient with scleroderma patient to rule out the diagnosis of pulmonary arterial hypertension. And the big question that comes here, that why pH is a killer in CTDs. And as you know that, if you look at that in general, and you look at to the aggressiveness and the mortality of pulmonary hypertension, it's scored very high. It's worse than most known cancer, actually. Maybe the only 2 worst cancer are pancreatic and lung cancer. All other cancers have better outcome when it comes to the pulmonary arterial hypertension. And when we try to look at the predictor of mortality in those patients who have PAH, as you can see, scleroderma basically scored the first. It's much worse case scenario when you have this combination of scleroderma and pulmonary hypertension. And as they showed you that the mortality in those patients is much more higher compared to other group of PAH, including idiopathic pulmonary arterial hypertension. Now, this is our own series a few years ago, looking at the first 100 patients that we looked at in our center. And you can see that those patients who have, for example, congenital disease PAH, congenital heart disease PAH, or idiopathic, they had significantly better outcome than those patients who have scleroderma associated pulmonary arterial hypertension. Now, when we try to look at the characteristic of the disease in PAH patient, basically idiopathic PAH comparing to scleroderma patient, we notice that scleroderma patients are actually older and they have much lower diffusion capacity when it comes to the lung function test. However, when you look at the hemodynamics, it seemed that PAH patient, actually they have what looks like milder disease. If you look at it, their pressure is lower. Their actually PVR, which is pulmonary vascular resistance, is lower than those patients who have, for example, idiopathic PAH. So always become like, then what's happening? Why those patients who seems to have milder disease, they have a poor outcome? one of the observation notes that although what looks like mild disease and that those patients who have minimal symptoms, if you follow them, the vast majority of them will progress very, very rapidly into more severe disease. And also, a different study trying to look at what happened to the myocardial perfusion in scleroderma patient compared to the control, those patients who have scleroderma without pulmonary hypertension, and trying to look at the cardiac perfusion or myocardial perfusion. And as you can see that uh, whenever at rest, there was similar perfusion, but with exercise, normal scleroderma patient, when I say normal, they have no PH, they have much better perfusion to the myocardium, while this is significantly blunted when it comes to the scleroderma PAH patient. And again, looking at the different perfusion to the right heart and the left heart in those patients who have scleroderma without PH or scleroderma with the PH, you can see that the cardiac perfusion is significantly blunted in patients who have scleroderma PH. Now, the other possibility is what we call the RV-PA uncoupling, that normal individual, whenever the RV contract, the pulmonary artery has to dilate to accommodate that increase of free cardiac output in the early systole. But this is really blunted because of the stiffness of the vessels in scleroderma patient, leading to RV-PA uncoupling that might lead to the worst outcome in those patients. And because all of these factors and increased mortality, screening is becoming extremely important in those patients. Now, if you look to different studies, whether this is Saudi studies, Saudi data, the first author was Dr. Hadid Al-Altair, that was published a couple of years ago, showed that the significant number of patients that came to us as CTDs PAH, they arrived to us very late in functioning class 3 or 4. And this is a replication to what's been noticed everywhere, including the French study and other studies. So the idea of screening is trying to pick up patients much, much earlier. And one of the protocols that's been endorsed by most guidelines is the DETECT study, which was cross-sectional international study trying to look for evidence-based algorithm to pick up patients who are asymptomatic PAH patient. So the population was age of 18 and above. They have definite diagnosis of scleroderma for 3 years, low DLCO, FVC more than 40%. And they subjected them to 2 steps diagnostic algorithm. So they look at step 1, those patients who have those 6 characteristics. They look at the FVC over DLC ratio, anti-centromere antibodies, telangiectasia, pro-BNPs, right axis deviation, and serum U rate. And they give specific scoring for each item here. If the patient score more than 300 points, they move to step 2. If not, then PAH is very unlikely, and the patient will not proceed to echo, but will be rescreened next year. However, those who scored more than 300, they will have echo, looking for the right atrial area and TR jet velocity, again, giving different scoring for each item. If the patient scored more than 35, then they would proceed to the right heart cath. And this looks like complicated, basically, algorithm, but now there is actually an app that you can have it on your cell phone, just like put down these basically items, and it will tell you who those patients who need to proceed to the to echo and then to right heart cath, or then stop there and just repeat the screening next year. Does it work? Yes, it does. And this is the French study by Marc Humbert found that those patients who were screened, you can see that we were able to pick much, much more cases at an earlier stage of the disease. About 40% only will be picked up late, compared to about 75% if you don't screen your patients. And furthermore, if you look at whether that certainly yes, those patients who were screened and treated early, they had almost double or triple survival compared to those patients who were not screened. So, and of course, I don't need to say that screening means patients who have no symptom. They only have scleroderma, but they have no pulmonary symptoms whatsoever. However, if the patient has symptoms, then we need to put them into diagnostic algorithm trying to pick that up. And now the diagnostic algorithm has been kind of really summarized in the recent Sixth World Congress. Basically, patients who have symptoms should go for echo. If you have high risk for PH, then hello. Rahman. Those patients might have a worse outcome. Of course, we do imaging to look for the lung parenchyma, looking for basically obstructive or restrictive lung disease. And also, it can give you a hint that there might be some associated features such as a dilated esophagus and hiatus hernia, which is quite common in patients who have scleroderma patient. Of course, VQ scanning is as well extremely important to rule.
Doctor, can you hear me good, please? Okay, please,
Yes,
we cannot hear you over there. There is some mistake in your voice, so can you repeat another time, please, from the beginning your presentation, if you don't mind? Thank you very much.
I don't understand. What do you want me to
Can
do?
you repeat, please, the presentation from the beginning, because we didn't hear your voice from the beginning. Thank you very much.
Okay, but this is recorded. So you want me to do it live?
No, from the screening part, we have a problem. Yeah.
Okay. So should I do it just live instead of
Just a
having
quick review, then we'll go through the management from the starting of doing echo in the screening.
the right heart cath is not only important for confirming the diagnosis, but it's also important to further classify the disease. For example, in those patients who will have group 1 PAH, they will have high pressure, low wedge pressure, and high PVR. So you need all of that hemodynamic to categorize the patient into group 1. While, for example, those patients who belong to group 2, those who have left heart disease, which again could be part of the scleroderma, or you can have a myocarditis, or you can have diastolic heart failure. In those patients, you have high pressure, low PVR, and high wedge pressure. So again, that will tell you that this is a different category of pulmonary hypertension that you need to deal with in a different way. And sometimes you have complex cases where you have combined pre and post capillary pulmonary hypertension. So this is why in the pulmonary hypertension field, we keep saying right heart cath is a must in those patients. It is never optional. So whenever you confirm the PAH subtype, as you else is negative, but it could be infection related, for example, HIV related or schistosomiasis. Also, which is the topic in this in basically lecture, it could be CTD related. And in those cases, we do anti-centromere antibodies, we look for double-stranded DNAs, we look for the anti-Rho, we look for basically RMP, U1 to U3 that have different implication and associated with different type of the pulmonary hypertension. And of course, we look at the anti-cardiolipin antibodies, which is a marker for really increasing clotting events that put the patient more likely in group 4, chronic thromboembolic pulmonary hypertension. Of course, we also look for the liver function test to rule out basically portal pulmonary hypertension. We look for the thyroid and for hemolytic anemias that put the patient in category 5 or group 5. So my take-home message to you, ladies and gentlemen, PAH should always be considered in the differential diagnosis of exertional dyspnea, syncope, and angina, in particular in those patients who have risk factor for pulmonary hypertension, to great extent CTDs, and very specifically scleroderma patient. Screening for PAH and scleroderma patient is a must, and it's been now endorsed by all guidelines. This has shown to enhance early picking up the cases and hence early treatment and significant improvement in the outcome. And the DETECT study has been endorsed by most guidelines, including the Saudi basically guidelines, when you have 2 steps of care, but you need to remember that the DETECT is only applicable for those patients who have scleroderma for at least 3 years and they have low DLCO, lower than 60%, and FVC more than 40%. In other patients, you need to look for really other parameters, such as looking for lung function and DLCO. You need to do an echo, pro-BNP, and other diagnostic modality. When it comes to the diagnostic modality, we did talk about the role of echo that has really evolved significantly lately as a screening tool for pulmonary arterial hypertension or pulmonary hypertension by the TRG velocity and other echo factors that will determine which patient that should go to the right heart cath, which is the gold standard in the diagnosis. And with that, I would like to thank you so much for your attention.